Thank you, Dr. Mohammed. Hello, everyone. First, I would like to thank the organizer for the invitation. I was going to ask a question, but we'll do it later. And I would like to thank Abdullah for this nice case presentation and sharing a complex case.
Ask each other again, so prepare yourself.
We're gonna talk. So my case is a 44-year-old gentleman with no known previous medical history. He presented to a peripheral hospital with inferior STEMI. He was treated with lytics, but it was not successful, so he was transferred to us for rescue PCI. These are his vitals when he presented to us. So he's pre-shock, maybe shock class B, based on SCAI. His troponin was elevated and he was in acute kidney injury. This is his angiography, initial coronary angiography. As you can see, there's a balloon pump inserted because of the hypotension. And you can see he has severe stenosis of a large OM, and he has a CTO of the mid-LAD, and he has occluded RCA. So at this point, the patient was becoming more hypotensive and the pressors were up titrated. So as you can see, cardiogenic shock is a dynamic process. The patient will be in a point and that can be changing over time. So at that point, Dr. Musa and Dr. Ahmed Imam, both of them are present here, were involved in this case and gave help to the operator. And they upgraded the balloon pump to an Impella CP. And they started performing PCI. They did a beautiful stent to the RCA, which was the culprit. But given the patient was hypotensive and having some chest pain, they went ahead and opened the OM as well. So I got involved in the case day one in CCU when I was rounding. I saw the patient. The patient is young, but he looked unwell. He was not intubated. He was on Impella CP. So for our protocol in our CCU, anyone with mechanical support, they have to have invasive assessment with monitoring. They have to have a SWAN. So his mixed venous saturation was 30%. So for people who are not used to seeing these numbers, the normal should be anywhere between 60 and 70%. People in their shock, they can be 50%, 45%. So 30% is really, really severe shock. And his CVP was elevated at 15, cardiac index was 1.4, and the colleagues eloquently described the hemodynamics before me, Dr. Haidar and Dr. Abdurrahman. His PAPI, which is the pulmonary artery pulsatility index, which is, if it's less than 1, suggests the RV involvement as part of the cardiogenic shock was reduced at 0.7. And this is despite being on noradrenaline, levosimendan infusion, and Impella CP. And he has worsening of his renal function, evidence of shocked liver with his liver biochemistry being in the thousands club. His bedside echo showed an EF of 20% and his RV was dilated and was barely moving. So at that point, my feeling that the patient now is continuing in shock, and the main reason because he is an RV failure. And I think that's one of the important points to make, that when the RV fails, it just dilates a lot. So this is acute. It's not used to fail like this, so it will dilate immediately. So I took the patient to the cath lab to upgrade the system from Impella CP to Impella RP or to Bipella. But I wanted to show this slide because by the time the patient was ready, I was trying to cross, you look at the Impella CP, it's been pulled. So this is very important when you are mobilizing these patients, that these devices can move in and out and cause problems. So we have to be very careful with that. The other point of showing you this video is that we are not, as interventionalists, we are not very used to crossing the tricuspid valve very frequently now, unless you're doing pulmonary valve implantation like Dr. Wa'el. So you need some tips and tricks to go up. So here you can see me went up, used the JR, and I went up into the pulmonary artery. This is another case I did, just to show you the Impella RP passing through even a biprosthetic tricuspid valve, and you can see it moving nicely and smoothly. But the trick for this is the manipulation, clockwise to make it bend and counterclockwise to straighten the device. So this is important when you are crossing the valve. Anyway, so at this point, the patient is now on Bipella. So fully percutaneous heart support for biventricular cardiogenic shock. So some tips and tricks, to derive benefit from these mechanical support devices, you don't want to have complications. So you have to have a very nice technique with vascular access, because most of the problems that happens with mechanical support is bleeding and access related complications. So if you're causing bleeding and mechanical access complications, you're not going to see the benefit you're trying to give to your patients. Crossing the tricuspid valve, I already talked about it. I think the easiest thing to use if you don't cross the tricuspid valve frequently is to use a wedge catheter to get you up to the pulmonary artery. You have to have your wire very placed distally and the torquing of the device as you go up. So this is our patient in the CCU. You can see the devices side by side, Impella CP and Impella RP. And you can see it in the fluoroscopy sitting there. Of course, the Impella RP is much bigger device. It's a 22 French. The Impella CP is much smaller. It's 14 French. But they give similar kind of cardiac output between 3.5 to 4 liters per minute. So this is an important slide just to show the impact of one day being on Impella RP. So when we started, the CVP was 15. After we inserted the Impella RP, it dropped by 33% to 10. The mixed venous saturation, which was really concerning for me, at 30% improved to 55%. So that's a huge improvement. Even the cardiac index improved from 1.4 to 1.8. So the LV, for it to pump blood forward, it needs blood from the RV. And if the RV is failing, the LV will not have enough preload to give you a sufficient cardiac index. The PAPI, as you'd expect, improved from 0.7 to 1.3. Lactate improved significantly from 1.8 to 1.4. The liver biochemistry started to improve significantly very quickly. Again, this is only after 24 hours. So the patient was on Bipella for about 6 days. Both of them were removed. Of course, our usual technique is before removing the mechanical support, we'd like to have the pressors at minimal doses. Otherwise, if the patient is still in high doses of pressors and you remove the mechanical support, the de-escalation will not be successful. And sometimes we use the Digoxin for inotropic support as well as an oral therapy. So the total course in hospital, the patient stayed 14 days in the CCU, 14 days in the ward, required multiple dialysis sessions. Lactate was stable 1.5, and the patient was mobilizing in the ward. At the time of discharge, which is after a month, almost a month in hospital, the kidney function recovered to 120 roughly. So he was off dialysis. Liver biochemistry came back to normal. Patient was euvolemic, and he was started on triple therapy for heart failure. And the plan was for possible LAD, CTO, PCI in the future. If you remember, the LAD was not revascularized because it was CTO. So this case was done in 2020. Last week, we checked in the patient. He's still alive. He's in his 40s. He's an electrician, so he's back to work to support his family, completely asymptomatic. At 1 month after the procedure, back in 2020, this is his EF. The RV function is improved significantly. He continues to have 25% to 30% LV systolic dysfunction, but clinically, he's doing really well. This is at 3 months, no major changes from 1 month. So to conclude, and I think mechanical support can be useful in cardiogenic shock, but I think you have to match the degree of shock to the degree of mechanical support that you're providing. So don't expect you treating someone with SCI class C or D with a balloon pump and hope that that will work. It will not work. So you have to match the support to the degree of shock. If you're going to use mechanical support, don't wait until the patient is terminal and then you put them on ECMO and then put them on Impella. It's not going to work. If you want to use it early, and you have to be aggressive in instituting it, and you have to be aggressive in de-escalation as well before the patient develops complication. If the patient has cardiogenic shock due to biventricular failure, you have to support both ventricles. It's reasonable to start with the LV support and don't wait too long. If the patient is not improving, go ahead and uptitrate or escalate to biventricular support. I think it's really crucial to use hemodynamic assessment with SWAN. If the patient, my role in the CCU, patients on mechanical support, they get a SWAN. Because without SWAN, it's like you're driving a car with your eyes closed. You have to know how to escalate, how to de-escalate, and use both hemodynamic, use the mixed venous saturation. It's a very, very easy blood test, very useful. And you use your imaging with echo. Thank you for your attention. This is the patient, by the way, with his permission.
Thank you very much.